Welcome to Pink Week 2022. My name is Dr. Winifred Leung, breast radiologist at Sansum Clinic Ridley Cancer Center. Thank you to the Breast Cancer Resource Center for inviting me to speak about the myths of mammography. Alliteration aside, I hope I can share some common questions that pop up in my practice, along the way discuss the types of imaging we use and why, as well as tease out fact from fiction. I hear this one a lot. I'm not worried because no one in my family has cancer. 85% of women with breast cancer do not have a family history of the disease in first-degree relatives, mom, sister, daughter, or second-degree relatives, grandmother, aunt, niece. Additionally, only 5 to 10% of women with breast cancer have a known gene mutation. Hereditary gene mutations, with BRCA1 and 2 being the most well-known, along with a whole host of others, are the minority. The vast majority of breast cancers, 90 to 95%, do not involve inherited mutations, but are sporadic mutations that are not passed from parents to children. So family history is just one risk factor. Others include getting older, longer exposure to estrogen and progesterone, alcohol, a sedentary lifestyle. But risk factors don't cause cancer, they just affect your chance of getting cancer. While we know a little bit about risk factors, why some women develop breast cancer and others do not, unfortunately, still remains a mystery. So what are the recommendations? Multiple medical organizations recommend screening, that is looking for disease before there are signs and symptoms at age 40. Women with family history of breast cancer and a first-degree relative may start screening 10 years prior to the age of diagnosis in that relative, but not before age 30. Diagnostic imaging occurs when there are symptoms, for example, a lump detected on exam, a change in breast shape, including dimpling of the skin or retraction of the nipple, bloody or watery nipple discharge, as well as an abnormal screening mammogram. Speaking of abnormal screening mammograms, getting the phone call that you did not pass your screening can cause a lot of anxiety. Without some background information, it's easy to jump to the conclusion that abnormal mammogram equals cancer. What a callback really means is that the standard views for screening did not provide enough information, and we need to take a closer look, because I've either a change from one year to the next or a new finding that could be either nothing at all or a benign finding. Radiologists have a very low threshold for risk. We want to be over 98% certain that an exam is benign. If there is less than 2% chance of malignancy, we will usually ask for follow-up. To put this into perspective, let's run some numbers. Out of every 100 women who get a screening mammogram, 90 are told that everything is fine and to come back in a year. Out of the 10 that are asked to return for either additional diagnostic mammogram, ultrasound, or both, 6 will be reassured that everything is normal. 2 will be asked to return for short-term follow-up, usually in 6 months, and 2 will be recommended to have a biopsy. Out of those that have biopsies, only 25% turn out to be cancer. So you can see that not passing a screen just means missing information. Most people will not need a biopsy, and of those who do have a biopsy, most will not have breast cancer on final pathology. Mammography is ineffective is something that I see on news feeds and social media. I would rephrase this to say that mammography is imperfect. What we do know is that it's the best tool that we have for breast cancer screening, with the oft-cited statistic that breast cancer mortality has dropped 30% in the last 30 years that screening has been prevalent. Specific numbers on how good the test performs varies, but Breast Cancer Surveillance Consortium data shows a sensitivity of about 87% and a specificity of about 89%. In other words, the test correctly identifies the disease in 87% of people who have it, and of the people who don't have it, 89% of them will test negative. What is undeniable is that sensitivity drops in the setting of dense breast tissue. On the left, we have a non-dense breast, which is comprised mainly of gray fat. We can easily see this small cancer, which is round and white, next to the red arrow. On the right, we see a mammographically dense breast, which has much more white breast tissue and obscures our target, which is also white. For women with dense breast tissue, a supplemental screening ultrasound closes the sensitivity gap. On ultrasound, background dense breast tissue remains white, but the target is dark, thereby increasing the sensitivity of cancer detection. You can see that this would not be helpful in a woman with fatty breast tissue where the background fat is dark and the target is also dark. Here is a case where supplemental MRI was used for high-risk screening. The cancer is nowhere to be seen in the setting of mammographically dense breast tissue, but is obvious on the center and right MR images. Which brings us to the next myth. My ultrasound or my MRI or my thermogram was normal, so I don't need a mammogram. First off, thermography is not a recognized modality for breast cancer screening or diagnosis. The American College of Radiology actually has a position statement against the use of this technology. Even though it was FDA approved in 1982 as an adjunct to mammography, multiple studies since then have shown unacceptably low cancer detection rate. Not surprising, since it's based on the premise that cancers emit heat, and that's just simply not true. Infections emit heat when you have mastitis, for example. I've seen too many advanced breast cancers over the years with the patient in disbelief because she's holding onto a normal thermogram. It's heartbreaking and it's outright dangerous because it gives women a false sense of security that their breast imaging is normal. How about normal screening whole breast ultrasounds? I have a cohort of patients who don't want to have mammography because of radiation, which we'll touch upon next. Ultrasound is good at finding masses in the setting of dense breast tissue, but not good at finding masses in a screening setting with fatty breast tissue. It's also no good with microcalcifications, which often accompany breast cancer and can only be seen on mammography. How about a normal MRI obviating the need for mammography? This actually has some validity. For example, in young patients with very high risk BRCA mutation carriers, we'll often recommend starting MRI before age 30, and some have suggested waiting on mammography till after age 40. I think that this is a reasonable approach given the very high sensitivity of MRI. Radiation exposure during mammography causes breast cancer. Simply no. To date, there's no proven case of breast cancer arising from mammography. When studies talk about this theoretical infinitesimal possibility, they're extrapolating from computational models based on nuclear disasters like Hiroshima and Nagasaki. The theoretical risk of radiation-induced breast cancer is far outweighed by the real benefit of screening for a common cancer. To put this into perspective, the effective dose from screening TOMO is a little less than 3 millisieverts. This is comparable to 1 month of natural background radiation that we get from the food we eat and the radon around our homes. It's equivalent to spending 2.5 months in a higher altitude place like Denver, or equivalent to approximately 7 flights from New York to Los Angeles. While not many women truly believe that mammography causes breast cancer, people are rightly concerned about the amount of radiation they're receiving from medical imaging. The truth is, with the advent of ever-improving technology, the diagnosis of a lot of medical conditions now weighs heavily on radiology. For example, if you have a cold and go to the ER, you'll need a chest x-ray to diagnose pneumonia. And if there's something concerning on your chest x-ray, you may end up with a chest CT, which is equivalent to 2 years of background radiation. These amounts are not negligible, but when there's a reason to do the study and the benefit outweighs the harm, then we use the principle of ALARA, an acronym in radiology meaning as low as reasonably achievable. This is a reference chart sponsored from the American College of Radiology to educate patients and put radiation dosage for many common procedures into perspective, and can be found at radiologyinfo.org. Okay, so radiation aside, what about other harms? Mammography requires the breast to be compressed both to obtain a clearer image and to decrease the amount of radiation needed to perform the exam. Technicians adjust the force of compression based on breast size, skin tautness, and it's usually performed to the point where it's slightly to moderately uncomfortable for about 5 seconds per view, 2 views per breast, so 20 seconds total. I've been asked several times if compression can cause cancer or cause cancer to spread. The answer is no and no. Cancer does not move like toothpaste. Cancer is abnormal cell signaling resulting in disorderly cell growth and cannot be physically squeezed from one area to another. How about implants? I'm frequently asked by my ladies with breast augmentation whether or not mammography can harm their implants. My answer is extremely rare, but not impossible. An average mammogram generates about 20 pounds of compression, but an average implant can withstand over 100 pounds of force. Additionally, I often tell my patients that implants don't last forever, usually around 20 years. And just as we don't expect the tires on our cars to last forever, we don't stop driving or taking road trips because we're worried about wearing down our tires, nor should we worry that hugging our loved ones or being athletic or having mammograms will lead to the demise of our implants, which is inevitable. What about the criticism of overdiagnosis? When public health officials quantitate the value of a screening study like mammography or PSA for the detection of prostate cancer, the calculation they use for quality-adjusted life year is based in part on reducing mortality. In a nutshell, overdiagnosis refers to finding small cancers or precancers on imaging that wouldn't end up being fatal if left unfound and untreated. A good example of this may be low-grade ductal carcinoma in situ, DCIS. Currently, we detect these as microcalcifications on mammography, and if biopsy shows DCIS, they're treated with partial mastectomy. Unfortunately, we don't know which of these low-grade entities stay indolent and which become high-grade or aggressive cancers. This is an active area of research, so stay tuned. False positive refers to alarming findings on imaging that result in a benign biopsy. This incurs not only cost to the patient herself, but also to the healthcare system as a whole, and more poignantly, creates distress and anxiety. However, I believe that women who are well informed about risks and benefits and who accept the value proposition of screening, in other words, buy into preventative health and are willing to accept the potential ups and downs, are resilient enough to mitigate anxiety and distress, which usually stem from uncertainty. When I recommend a breast biopsy, I'm occasionally asked if breast biopsies can be dangerous. The question usually comes from several different angles. Some women are worried that sticking a needle into a cancer can cause it to spread, a phenomenon known as seeding. Back to the analogy of compression in toothpaste, though, cancer is disorderly cell growth and not an oil spill. Violating the borders does not dislodge cancer cells to become metastatic disease. Other women are concerned that a needle biopsy is not as accurate as surgery. The diagnostic equivalency between needle and surgical biopsy has been so long established that core needle biopsy is now the gold standard for diagnosis. In fact, when this is not done, we must justify why surgical biopsy was performed, as it is costlier, requires anesthesia, and is obviously more invasive. Some women are talked into having a previously biopsy benign lesion removed so that they can be assured of a definitive diagnosis. This is wholly unnecessary. Unless there's a concern such as continued growth after a benign biopsy, or if the pathology doesn't match what's expected on the radiology, what we call radiology pathology discordance, there's no need to remove a biopsy-proven benign mass unless a woman desires it for cosmetic or other personal reasons. Men do get breast cancer, and although it is rare and represents less than 1% of overall cases, when it does occur, we worry that there is an inherited gene mutation, and the NCCN recommends genetic testing for all men diagnosed with breast cancer. Most men undergo mastectomy as opposed to removing just a part of their breast, given that they don't have much tissue anyway. The removed breast obviously does not need a mammogram, but there aren't guidelines for continued screening of the opposite breast. In my own practice, I like to recommend that men who don't have gynecomastia or breast tissue rely on self or clinical exam because new lumps and bumps are more readily detected by feeling underneath the skin than by X-ray. Transgender people don't need mammograms. That's not entirely true. For transgender and gender non-conforming individuals, mammogram recommendations are based on the use of hormones and the degree of surgery. So for male to female individuals who've been on 5 or more years of feminizing hormones, annual mammography is recommended starting at age 40, earlier if they are high risk. For female to male individuals who have had complete top surgery, there's no need to screen. just like women who've had complete mastectomies no longer need to be screened. But if they've only had breast reduction or no chest surgery at all, then they would start annual screening starting at age 40. Imaging surveillance strategies for women with personal history of breast cancer is a top question that I field not only from women, but their doctors as well. Unfortunately, we don't have a clear-cut answer. The American Cancer Society doesn't recommend breast MRI for routine surveillance of asymptomatic women with personal history of breast cancer because of insufficient evidence of benefits and harms, mostly falling under the category of overdiagnosis, which we discussed earlier. On the other hand, the American College of Radiology in 2018 revised recommendations to include MRI with mammo in women with personal history of breast cancer if they were diagnosed before age 50 or if they have dense breast tissue. Currently, there are about 3.8 million women who are breast cancer survivors in the US. Understandably, women who have gone through breast cancer treatment are willing to go through a lot to make sure that if their cancer returns, it's detected as early as possible. Also understandable is that extra tests can be inconvenient, expensive, and create anguish. I think as we wrap things up, this brings me back to the idea that individualized breast radiology must factor in value reflection. Although I've reviewed what the guidelines are, there are factors that may be more important to one woman than another. For example, some women would rather deal with false positives than the possibility of missing anything at all. Other women find the anxiety of coming in for a mammogram overwhelming. Another woman might have claustrophobia that's uncontrollable even by anxiolytics. I often tell my patients that I'm not the mammo police. I'm more of your accountant. I'm here to give you advice and information so that you can make fully informed decisions about your health. With that, I'd like to thank everyone for listening today. I also want to thank the Breast Cancer Resource Center for everything they do in support of women who are going through or who have gone through breast cancer. The work that they provide to our community is so vital. Thanks, and have a great Pink Week, everybody.